Hey guys, welcome. Today we have got a really cool case presentation. Dr. Mustafa will be joining us soon to give his presentation. It's a full mouth rehab. Really cool case.
Hey,
And here he is. How's things?
how are you?
I'm good.
Dr. Kazi,
Yeah.
right?
So, Dr. Mustafa, where are you from? Just quickly before we dive into the case. I know the guys will be, dying
I'm
to
from Cairo, Egypt.
Yeah.
Yeah.
Perfect. And how long have you been practicing?
I've been practicing for 10 years.
Awesome. So you've got quite a bit of experience then, on top of me, 3 years.
Yeah, just finished my PhD degree in the Cairo University,
Yeah.
Department of Fixed Orthodontics. And it's going good. We're live, right?
Yeah, we're live. I'm just going to line it so we can see properly.
Take your time.
Guys, let me know how that looks. Okay, let's go to the start. There we go. Yeah, so I'm really excited about this one. I was scrolling through Style Italiano. Guys, if anyone's watching and has got their PC next to them, you can head over to Style Italiano and follow along the slides as we go through them. I saw this on Style Italiano and I was thinking, this is the most well-presented case I've seen in a long time.
Thank you.
So that minute I messaged you and
Yes.
and I was like, brother, please come and do this on a live session with me. And here we are 1 week later. So yeah.
My pleasure.
Shall we dive into this then? Because I think that's what the people are waiting for.
Yes, for sure.
Let me just move my camera up slightly because I think we're going to do that. Perfect. Right, so ignoring the signs is a good way to end up at the wrong destination. What were you talking about there?
Since day one in dental school, I've been fascinated by occlusion. I don't know why. I like the shape of teeth very much. I like the function. I like the aesthetics. I wasn't into the perio issues and composite. I was more into occlusion. I liked it very much.
Yeah.
So after graduation, I wanted to get along with the department that fits with my mindset. So I started doing cases in my master's, during my master's degree in Cairo University. So I was fascinated, like I told you before, by the full mouth rehabilitation cases. And I started to read a lot of, with a lot of doctors. I wanted to know more theories, the philosophies behind such big cases. And what I came up with, that there are a lot of schools that you can join, but the most important thing that you have to know that there are boundaries for your for any case that you have. There are solid grounds that you cannot cross. So what I meant by the title is that if you ignore the science, whether it's aesthetic, whether it's functional or biological, mechanical, then the whole case is going to crumble down. So I just wanted people to know that you should highlight some stuff during diagnosis and treatment planning, so you would get predictable results later on.
Perfect. Yeah. So let's go.
So it fits. It fits. It really. This title really fits this case.
Yeah, really important. As when we go through, you've pointed out a number of things that if you didn't address, the case would, fail essentially, isn't it?
Yeah, exactly.
Hello to everyone who's just joined. Victoria, if you're looking for the slides, it's Style Italiano Facebook. Scroll down for Dr. Mustafa El-Shabrawi's post. It's from last week, 31st of March.
This case was also nominated for the, if you know the RIPE global group on Facebook too, it's nominated for a prize. So if you can go and check it. It will be the first case on their page if you can find it on Style Italiano. But it's there, don't worry.
Yeah, perfect. And yes, this will be replayed on YouTube. So if you miss it, guys, or you need to head back onto YouTube. Link is in the bio to find that, and we will be we'll be there. If you're watching back on YouTube, make sure to subscribe and like and all that stuff. Okay, so let's look into the case, man, because that's what we're here for.
Yeah.
So slide here. Okay. Do you want to present what the patient came to you with?
Actually, it was very funny. This patient came in. She lives in Canada. She didn't want to do any more dental work in her mouth, but one of her relatives, she's my patient and her husband is my patient, and they became very close friends at my clinic. So
Yeah.
when she came to Egypt, she had a lot of work done at her previous dentist in Canada, and she wasn't very enthusiastic about changing anything else, because everything that she has done, it just doesn't fit with her face, it doesn't fit with her life. She's not satisfied with anything she has in her mouth, and she doesn't have any pain related problems. So she just feels great dismay about how her facial aesthetic looks.
Yeah.
And she wasn't totally trusting that things could really change until I started. We're going to discuss it along with the case, but I had to make the patient participate in every single step that I was going to plan for. And I have a previous case also that I posted on Facebook before this case 2 months ago. She saw it. She knew that there's something called, I believe in it very much, it's called slow dentistry. I believe it was introduced by Dr. Miguel Stanley in Portugal. It's not just a quick fix. You need to take some time. You need to plan. You need to make the patient participate more in order to get good results.
You had like a number of different try-in stages with changes to make for the occlusion and stuff. So not a quick wham and bam, one stop, sort of case. And she had PFMs on all the upper arch. And
actually, the upper right bridge you see in this case, when she was just complaining about her teeth, she was just discussing with me, I hate my teeth, I hate how they look. In the third time she said, I hate this upper right bridge just popped out of her mouth. So things were really failing for her, mechanically and aesthetically.
So there's a big amount of change to be made. So this here is the extraoral picture here.
Getting along this case, you will feel that I have my mindset. I tried as much as possible to translate it to the people, because I wanted to do this presentation not to attract anyone else, but the upcoming generations. I wanted them to know. I was just sending a message that if you go up with a well-planned case, you can understand occlusion and you can start working on such cases, of course, but you have to have strong basis from dental school in order to perform such cases.
It came across very well, which is why I was so intent on bringing you on.
Thank you very much. My pleasure.
Can you explain what we're talking about when you say the X position?
I attended the first big conference when Christian Coachman, of course, I don't know if you've been, you know Christian Coachman, he's the founder of the DSD. He came to Egypt in 2015. This was my first systematic approach to any case that I would do. And he just told us frankly, if you start by planning the upper right centrals, the upper centrals, either right or left, it doesn't matter. You can therefore go to any aesthetic outcome that you want to go ahead for. So the X position, my X position, with the letter X, I meant the most important, or the square number 1, in order to achieve an aesthetically pleasing case, whether it's a full mouth rehab or it's just a 6 anterior veneers case. So for me, in this case, I just wanted to make people know that we have some parameters that we need to address. For instance, in this picture, this is a rest position. For females, you can see that for females in general, if you have a 3.5 to 4 millimeters of incisal edge show, then you don't need to increase your incisal edge anymore. It will look very, very bad later on. So this is the X position.
And that 2.5 millimeter here is the amount of tooth on show for anyone who's not sure. Let's move to the next one. So you've got maybe a bit of a wider smile here. What were you looking at here? Obviously, we can see the lines.
I was looking at the lines with the horizon. As you can see, the dental line is not aligned incisally. As you can see, it's canted towards the right side of the patient, following along with gingival levels too. And by all means, this is not the technician's problem. Of course, the technician, he just follows whatever you send him, the impression, the tooth preparation. So what the lab did previously, the previous lab that did those teeth, he just took the teeth, he just made the canting upright on the bench. Then he started to build the teeth with the gingival levels. So I was just pointing out here that for us that we can't elongate the teeth incisally, so we have to go gingivally in order to have a less gummy smile.
Yeah, because you've already shown from this picture that the at rest is ideal.
Exactly, it's going down or going up. Yes. Yeah.
Perfect.
That's why in the next slide you'll see if the cement to enamel junction can bless this, because as you can see, as you know that we have to bond later on for this the ceramics for enamel. So bonding to cementum is questionable. Either you go for air abrasion or anything, but I like to keep my ceramics bonded to enamel as much as I can.
No, of course, that makes sense. Long term, you don't want to mess up with bonding and have things fall out and the patient come back to you. So yeah, for sure. Over here, we've got a Palito Class 2. You're checking the overbite and the overjet.
Yep. We have a 5 millimeters overjet, which was very difficult to wax in and to plan the case starting with. And by 0 millimeter overbite, it just meant that 0 millimeters of lower teeth are at display. And this has a huge displeasing effect for the patient's smile later on.
Yeah, we can just see the CEJ just around here, so really low. And this was really important in this case, isn't it? Anterior guidance.
Yep. I have such cases. I just imagine it in my mind. I have what I call, just for me, it's not in the textbooks or anything, but I'd like to make things easier for myself. I call it the occlusion box. The occlusion, any box, you have a top view. You have a top view for me is the vertical dimension of occlusion. You have the anterior part, which is the anterior guidance. You have the back part, which is the condylar guidance, and the sideways are your canine guidance or group function. So I just like to call it the occlusion box for me, the parameters, the place where I have my repeatable movements and where I set up my teeth.
Yeah.
So for this case, the 5 millimeter overbite, it made her anterior guidance absent at all movements. So this is why you can see that back teeth are totally flat, because all your protrusive movements are going to be on the back teeth, as the lowers, they barely touch. As you can see, they don't have any contact, and this is why you have a high osseous bone compensation. You can see that the upper, the lower center incisors, they are occluding on the soft palate, on the palate, sorry, on the hard palate.
Yeah, can you adjust your mic? We're getting a little bit of feedback. Try say something now. See if that's better.
Hi.
Yeah, I think that should be a bit better. We just had a little bit of rustling.
Can you hear me right now?
Yeah.
Okay.
Let's hope that's a bit better.
Okay.
Yeah, so you'd had the loss of anterior guidance here, and
which is very important.
Yeah, and we'll see on the next slide here. This is what I think a lot of people remember this from dental school and then quickly forget all about it. And the same with the curve of Spee.
Can you hear me properly?
Guys, can you let me know if Dr. Mustafa sounds okay there? Somebody in the comments, please. I think we're okay. Nobody's saying anything.
Okay. I hope that they are listening. It's a bit better now. Thank you, Victoria.
Thank you, Victoria.
Rusty, I hope it's a little bit better.
Yeah, maybe it's because it's rubbing on your shirt behind you with the wire. I don't know.
Yeah, right now it's better.
Yeah, perfect. Thank you. Thanks,
Okay,
guys. Thanks,
so
guys.
we have a question about the curve of Wilson.
Yeah.
The curve of Wilson is a side-to-side curve that we need to set up. We have different cuspal positions. It makes your chewing ability better. You have your cusps. You have cusps orientation. You have to have the buccal and lingual cusps higher at the upper and the lower in a different type of setting during your wax up and for your future restorations. If you go for the other, and this curve was purely flat because her previous dentist couldn't fit any teeth in there, because as we did later on, he didn't raise the vertical dimension of occlusion just to get proper restorative space to restore the curve of Wilson and curve of Spee, like we're going to see afterwards.
Yeah, so this is the very steep curve of Spee, which when you draw it out like that, becomes very obvious. So it's really important to do this analysis, right?
Exactly. Just for functioning is everything. The patient, the most easy part is the aesthetics. You can see aesthetics, but you can never predict proper function unless you have the curve of Wilson, a properly managed curve of Wilson, like I did with the Broderick flag, as you can see, Dr. Kazi. Then adjusting the curve of Wilson too, and you have a plane of Monson that we had in the final. We concluded with a plane of Monson.
Yeah, perfect. And you guys, if you want to read the slides, I know there's a lot of writing there. It's probably very small on my screen. You can check that out on Style Italian on Facebook, but we're going to move on to the next one. So here we're looking at the posterior teeth, and you've lost cusp to the cuspal height, basically, haven't you?
Yes. Previously, there was no any cusps. She couldn't eat. She told me that she had to cut her food in very small chunks so she could have a better digestion for anything that she had been eating, because even the uppers were very flat. She doesn't have cusps or deep grooves or anything. But I can't blame her previous dentist. Doing such cases, it needs proper. You can't do it. You have to do all the case just at once. You have to make the right and the left sides and the upper and the lower at the same time, so you could have better synchronization between the upper and the lower teeth.
Yeah, it's not an easy case. I mean, you make it look far too easy when you do it like this and we see the slides, but it is a very complex thing if you're not following the steps correctly, and you don't have that. Maybe I know you had some great mentors as well to kind of help you through, didn't you?
Yes, true.
So here we've got
upper arch.
Yeah,
as you can see, totally flat. I don't know how she has been living for the past 8 years. Totally unpleasing. I don't know how she can chew anything or grind anything with those.
Yeah, and wearing through as well in some areas, right?
Yeah, exactly.
So yeah, we can see it in the lower as well.
Yes, we didn't have much time. She lives in Canada. I live in Egypt. We didn't have much time to place an implant for the low right 7, as you can see.
This one here, yeah.
Yeah, but I ensured that later I made proper space with the final restorations to have proper space for the future implant there.
How important is it to you to be replacing posterior units? Because we have in some in the UK, for example, the idea of the shortened dental arch. Exactly. For me, it doesn't sit right. I feel like the more units we lose, the more biting pairs we lose, the higher risk of fracture and loss of further teeth. Is that something that you
totally
kind of subscribe to or not?
I totally agree. I just call it how much players do you have on the team? You have to have proper number of players. If the bone support is good for you, and the play and the inferior alveolar nerve is away, and you have a proper case and an easy case, you don't need to go for bone grafting in such an important and a risky area. Why don't you go for an implant? A short dental arch, I'm with it very much, but not in this case. I can put lower 7 it wouldn't be very difficult for me. As the case is, it's easy. But if I had shorter length, no, I would have skipped that.
Yeah, yeah. RX Massage, thank you, but we're not talking about vaccines today.
Maybe next time, next year.
Yeah, next time. Yeah. So this was a picture from the 90s. So you can see, very beautiful smile that she had previously. So this was the thing that you're working from.
I asked for it, and she told me that she has a picture. It's the best picture I could get out of her. Of course, it helped us a lot. She told me that things that she didn't like with this smile, but what I wanted to see very much is the retroclination. When I mounted the case on the articulator, she had retroclined anterior teeth in the 1990s, and right now, when I tried to procline them, she has very good lip volume. If I procline the teeth at any degree, it would have made a huge proclination. It wouldn't fit right with her teeth.
Yeah. So it's really important to see these things, and this is where she is at before you finished. When she came to you to start with, and we've got a very prominent canine here as well, haven't we? So things are not quite right.
No, wasn't right at all.
Okay, so then we're into face bows.
Okay, this is the second sign that you should be worried about. Of course, the first diagnosis with the incisal position and taking care of the curve of Spee and the curve of Wilson and everything else, you want to get your patient on a bench. She can go home right now, and I'll start planning with her pictures, with the videos, and with the face bow. The most important thing with the face bow is that you want to see the cant of the teeth in the articulator itself. You don't want to set up the teeth like her previous technician did before. It just made her canted teeth parallel to the floor. So if I did this again, would have made the canting more. Would have increased the canting. So this is why I go for a face bow. My face bow doesn't have those spirit levels. I like to use the spirit levels because I don't want to go with the interpupillary line because it wasn't parallel to the horizon, and her back teeth, I just went totally parallel to the horizon. It works very good at my hands, so this is why I use a spirit level with my face bow.
Yeah, perfect. So that's what we've got there. We're moving on to the next one. So we're talking leaf gauge as well. So you're trying to work out where that last contact is.
Exactly. I just want to know the first contact position. Then I wanted to test the static look that I wanted to have at the end. I wanted to see the condyles. I wanted to be in a more centric relation. And this is called the leaf gauge. It's for fast deprogrammation of your pain. If your patient doesn't have symptomatic muscles or any TMJ problems or TMJ disorders, you can go for such deprogrammers. And the leaf gauge is a very good one. You just place a number of leaves. Then you start asking your patient if she feels any contact at the back. And if she feels any contact, you have to increase another leaf until she doesn't have any contact, and you can check this with an articulating paper. Then you leave the patient for 10 minutes and you biting on this leaf, as you can see. Then you come back and ask her again, because sometimes during this period of during the 10 minutes, the condyles, they can seat more into the glenoid fossa, and you're getting closer to the CR position that you want to acquire in order to build the whole case in the most physiologic position for the muscles.
So this is purely because you are trying to reorganize the occlusion, reestablish the OVD.
Exactly.
So then you need to get into that CR, and of course,
this is another sign, Dr. Kazi. This is another sign. Going for the title of the presentation, this is another sign. So you went for the exposition, you went for the face bow, you went for the curves, the curve of Wilson, the curve of Spee, and this is another sign, which is the CR position.
Yeah, absolutely key in these kinds of cases.
Exactly.
And then after 10 minutes, again, you've then got total disclusion. So you know you're at 10 leaves. So is that like maybe one I don't know
Every leaf is 0.1 millimeters.
Yeah, so about 1 centimeter, not 1 centimeter,
Exactly.
1 millimeter.
But I increased this. She had the last leaf that I used was 19 leaves.
Number
And
19.
by the way, it gave me a very good. I don't know if you can see through the leaf gauge or not, but I had proper 2 to 3 millimeters display of the lower anteriors.
Yeah, you can just about see here and see some compared to in that first picture where there was 0 millimeters. You could barely see the CJ. So this is much more aesthetic when someone's smiling, and yeah.
Exactly. And by the way, you're putting the patient in a CR position, right?
Yeah.
But you're also raising the vertical dimension.
It's 2 in 1.
Yeah.
We have a question there. Any specific indications for using other deprogrammers like Lucia Jig, Kois?
Yes, of course. The two you mentioned there, Lucia Jig, you can use it for a fast deprogrammation at the clinic. It could take up to 20 minutes. But the Kois appliance, I can't read the name of the doctor who's sending it.
Arjun.
Yes, Dr. Arjun. The Kois appliance, I use it for the patients that I want to go for longer deprogrammation. If the patient can't orient his bite, if she has the TMD problem, I want to relieve the muscles and deprogram the muscle engram that she has, specifically in the superior lateral pterygoids. I want to have a more relaxed muscle equilibration during the bite registration for the CR. So this is why sometimes I go for the leaf gauge or Lucia Jig, and the Kois deprogrammer, I can send the patient home with it with specific instructions just to make her more deprogrammed into the CR position.
Yeah,
I hope
so
I answered that.
Different uses for each one, so it's depends on.
And if you look it up on the internet, you have a lot of other appliances that you can use as deprogrammers also.
And moving to this slide, we've got you're finally taking the registration. So what do you use to take these registrations? You're using a heavy body, light body?
Bite registration material. In this case, I use the Zermac from Italy bite registration material. I like it very much, but I started shifting to another bite registration material. It's called Futar from Kattenbach. It's harder. So during mounting of the articulator, I don't have any rebounds.
Right, yeah, and it's maybe a little bit more forgiving with air resistance and stuff.
Yeah, exactly.
Perfect. So yeah, this is then when we go to the mounting of the cast, what's happening here?
This is just a confirmatory picture that what I have on the articulator is the same that I have in the patient's mouth. I just took the first point of contact and I marked it with the articulating paper. Then I did it on the articulator again, and I got the same points. It was on the lower left canine, which was very, very unpredictable. You'd have your first point of contact on your molars. So having it on the lower left canine just makes you know that she has pretty much flat anatomy.
Right. Yeah. So it's that loss of the cuspal inclines coming back to show its face again. Exactly. Any changes? Question again. Any changes that you would do in this particular area here if the patient had TMJ or TMJ clicks? What
would I do?
Yeah.
I would go for splints. I would treat the TMD first. I would never address restorations in a symptomatic patients. It's a red line. Never do raise the vertical dimension of occlusion in a symptomatic TMD patient. If you have an asymptomatic TMD patient and the patient has already adapted, as you can know, the anatomy of the TMJ, the retrodiscal tissues at the back, if they become fibrotic and they take the position of the disc, then it's asymptomatic, there's no pain, then you can go for vertical dimension of occlusion. But if you have pain, you can't.
Don't do it. Yeah. Yep. So the pain comes first always in your hierarchy of treatment.
Yeah, exactly. You have to address the elephant in the room. I wouldn't have a patient in pain and I'm taking a phasebo and I'm doing heroic ceramic stuff and the patient is in pain. She would never feel good even if you did the best treatment for her.
Mm. And then here we have you just you're setting up your Facebook, you're mounting. So on the fully adjustable articulator, are you
semi adjustable articulator? It's an articulator from BioArt. It's made in Brazil.
Yeah.
It's pretty popular here in Egypt. So the first case, I used the mounting jig of the face bow, and as you can see, the cast holder to mount the upper cast.
Yeah.
Then I used the bite registration I took with the leaf gauge to mount the lower. Then you have pretty much a CR position on articulator, and it would open the gate for you to go for a proper wax up.
Perfect. And do you mess around with Bennett angles and things at all?
I wanted to do that in this case.
Yeah.
But I just want to know from people, why would you go for such degrees? The 30 degrees for the condylar guidance and the 15 degrees for the Bennett angles. If you read about it a little more, it's more of a forgiving measurement, and it's a safe zone to avoid any interferences later on. You don't want to have the exact anatomy of the patient. This would make your treatment very complex, because whatever degrees that you're going to take, it's very accurate and everything, but you'd never get the elasticity of the periodontal ligaments, the elasticity of the TMJ on your articulator. So you have a lot of other measurements and discrepancies that would really hinder such degrees.
Yeah, so kind of overkill.
Yep. Yes, exactly. You're overdoing it. You're overdoing it.
Making the job too difficult. So
exactly. That's
it.
Yeah.
And here we've got your vertical component that you're checking, aren't you?
Yes. I just wanted to measure the vertical distance. I went from the centric relation to the maximum intercuspation. As you can see, I increased it by 2.5 for the posterior areas, and it would pretty much make you tell you how much did you raise.
Yeah. So that will tell you how much you've raised at the anterior of the mouth, that 3.7.
Exactly. Then you hit it. Then you multiply it by 1.5, and you put it on your incisal pin.
Perfect.
If you notice it, Dr. Kazi, there's a 1 to 2 to 3 rule. You can read about it. It's a very, very, very nice article that I've read about from Marcelo Calamita from Brazil. It explains it very, very, very well. So I just took this from there, from the literature.
And you've worked with that assumption of the 1.5. So
exactly. So I mounted my incisal pin at 3.75. So when I close my my articulator, my incisal pin, and get to the 0 position, I need to know how did I go from the maximum intercuspation, how the distance I went from the maximum intercuspation to the centric relation.
Yeah. A question again from Victoria. Is CR the same as the retruded position?
It depends. The CR is a bit retruded than your maximum intercuspation. But what do you mean with the retruded position? You'd never want to go for the most retruded position of the patient, as this is not a pretty much physiological or comfortable patient position for the patient. But yes, if you go for a CR position, you're definitely going in a more retruded way or direction.
Yeah. Thank you for the question, Victoria. So on this particular picture here, what is the yellow and the red line? I'm going to zoom in so the guys can see.
Yep. So as I told you, Dr. Kazi, I just closed my articulator.
Yep.
Until the teeth, they touched in a CR position. Then I marked with a yellow pencil on both the molars, the upper and the lower sixes. Then I took the pin back to the 3.75 as we've talked before, and I marked the red line, which you can see on the picture on the top right. I just took a red line and I made an indentation, or I made a mark to know where my the yellow line coincides with the red line, and this is the horizontal discrepancy that you have from your CR to the maximum intercuspal position.
Yeah, and then you have the 2 millimeter slide, which is comfortable.
Exactly.
Perfect. Arjun is asking, why do we have to check MIP, maximum intercuspation, and adjust the rod? Can we not wax up directly without applying the 1, 2, 3 rule?
Actually, this is a very good question, but the problem is you have to know that there's a degree of movement for the mandible. It's not a truly vertical position. You have to know that the 1, 2, 3 rule applies to the condylar movements that you have, and it pretty much gives you better restorative choices and restorative harmony between the distance that you've raised on the molar, which in this case it was a 2.5 millimeters on the back teeth, and it's 3.12 millimeters on the anterior teeth.
Yep.
So it pretty much fits with the condylar, with the arc of closure of your patient.
Okay, I hope that explains your question, Arjun. Thank you for that one. Let's move to here. So you're looking at 5 millimeter overjet, which was the initial.
Yes.
Yeah, and then we're moving afterwards when you're in CR.
And this was a huge blow while I was planning. By raising the vertical dimension of occlusion, you're truly also increasing the overjet. And I really wanted to close this overjet because I wanted to restore the anterior guidance, and I wouldn't have done it without making the lowers more proclined and increasing the thickness, of course, with proper thickness to restore the anterior guidance.
Yeah. And yeah, so it's gone to 7 millimeters, which is pretty large. So how did you overcome that?
Waxing. This is why I told you went from 5 millimeters to 7 millimeters. We have to see if it's waxable or not. I have to see. I have to start thinking about my material selection. I have to start really diving into the case and studying and doing a mock-up in the patient's mouth and checking the protrusive movements if it fits or not. Because 7 millimeter overjet is huge. This is why sometimes you can raise the vertical dimension of occlusion, as we said before. Then on the articulator, you're going to find out that it's too much. You can increase the VDO that you've already achieved during the leaf gauge. Taking the leaf gauge.
So that's a really important step. Then again, showing something that you've got to go for. What year in dental school do you learn this concept?
Undergrad? Never. Never.
Maybe one lecture with one slide.
Yeah, exactly.
Just skims over it. Yeah,
exactly.
So over here, we're looking at the palatal view, space created to design the anterior guidance. So this is
the whole aim for this picture. I just wanted people to experience how is it to study a case, to put in an articulator, to look at the vertical dimension of occlusion, to look at the space created when you do that, when you go for this, so that you can translate everything into the patient's mouth and start assessing it into the patient's mouth. Yeah.
So really important is all these cases is very planning based, and
exactly.
Once the planning is done, you're good to go.
Yes.
So here we're back to the steep curve of SPIE.
This is a very nice appliance or a very nice tool that I've been using. I used in this case. It's called the Broderick flag. The Broderick flag is actually you're getting the midpoint of the condylar guidance that you have coupled with the anterior guidance, and you're trying to harmonize the curve of SPIE to be in harmony with such important landmarks that you have to obey them at the end. You have to be very compatible with the anterior guidance that we are reproducing, and to be in harmony also with the condylar guidance that the patient already has. So Broderick flags really joins the middle part between those 2 points.
Right. So yeah, I've not seen this one before. So this was something that was new to me actually as well. So that was a good.
As you can see the flag up there, if you zoom in on the picture, on the upper right picture.
That's upper left, upper right.
Yes. You can see a silver line indented. Yes, the one you're tracing.
Yeah, just in case that's difficult for you guys to see, I'm just going to trace that one there.
Yes. If you can imagine, Dr. Kazi, the condyles on the articulator are right in the middle of this circle. If you continue this circle all around, you'll find that your condyle is right in the middle.
Yeah, so you're doing kind of like
Yes,
that. That's where it's closing off that line.
exactly. And the black line that I drew up with the pencil is generated from the lower canine. Then you're going to take the intersecting point between the two curves. And let's go for the next picture.
Over here?
No, the other slide.
Next slide. Next slide. Here we go.
Then you'll have the Broderick flag. It's going to cut the wax like the picture on the left.
Yeah.
Then you'll start. Yes, exactly. The pencil. This is your limit to have a proper curve of speed.
Right. So that's telling you don't go over this line, otherwise we're going to.
Exactly. And this gives you proper room for your upper molars and your lower molars.
That's it. And you can see the difference in height there, although the angle is slightly different from that side to that side.
Yes, the next picture, the one you're on right now, is after I respected the line that was drawn and put a little bit of anatomy just for the future wax up that you're going to see in the next slide.
Perfect. Arjun is asking what happens if there's high overjet, like in this case, but you can't get the guidance on the anterior.
You have to decrease the video, Arjun. You have to decrease it. But getting an anterior guidance, even if you decrease the overjet, but it will really help the patient and would really give you room to build steeper cusps. It doesn't have to be the steepest, but you have to bring in much chewing efficiency.
Yeah, because even if you did 3.5 instead of 3.75, let's say, you're going to have an improvement over what's currently there.
Exactly.
And then we have the functional wax.
Yes, and this is a very, very, very important step. Please don't go for any full mouth rehabilitation case until you have your finished patient with wax on the articulator. So this is very important for proper success of such case.
Let's see. I love these pictures where the wax up pictures. I don't know why. It's something very satisfying about them.
It's a shout out to my friend Dr. Amir Atallah for the great waxing finishing touches that he has done.
He's done there, yeah.
Yeah.
And then here we've got first started off with the aesthetic mock-up to get the patient motivated.
Like I told you before, she didn't have any trust. She couldn't trust anyone else. But when I told her before about the canting of the gum problems and the canting of the dental problems, then I went for the mock-up and she saw this picture. She just told me, I believe you, let's start.
Yeah. So this is really key for you here.
Yes, this is a picture from the Digital Smile Design. I know a lot of people they don't like Digital Smile Design much, but I want to tell you that doing cases before the DSD and after the DSD, no, I think that Christian Coachman really helped a lot of upcoming generations to skip years of experience and to put numbers on the paper, because as you know, dentists, we love numbers. We love the minimum dimension. We love the structural durability. We love knowing strength of the ceramics that we're using. So it really took up things up a notch.
Yeah, and Arjun's again asking about your thoughts on digital wax-ups. Is that something that you are looking into?
Right now, Arjun he's asking very important questions today.
Yeah, I think you should just take over from me.
I started the next case I'm going to post. It's pretty much more digital, but I'm a very analog guy. I like my wax dropper. I like my wax carvers, but definitely digital is going to speed things a lot, and it's more convenient and time saving, of course. But the thing is that I'm just still exploring the phase bow, not the articulator, the phase bow transfer to your digital software, whether you're using ExoCAD or any other software designing program.
Yeah, just to see how accurate that will be as well. So that's
exactly
key in these cases, isn't it?
Exactly.
Yeah, I hear you there. We are looking now at the new design transferred into all by the mock-up. And this is before you're doing your gingival surgery, isn't it?
Yes, exactly. So my periodontist up here, down here in Egypt is called Dr. Mohammed Atif. He likes very much to have the mock-up on the teeth.
Yeah.
Then he goes for bone sounding. Then he does some bleeding points and he cuts off the gums. Then he starts adjusting the osseous levels for biological outcome at the end, because you don't want to have ceramics with red gum margins for the coming 100 years.
No, I think that's probably the opposite of what you're wanting. So yeah, he's making sure we've got that 2 millimeters of
biological width.
Yeah.
Yep.
There we go. And here off they come. Again, yes. I love these. I love pictures when the old crowns come off.
It's like you're doing your territory, marking your territory. It's my case now.
You've finally this is when you've dived in. Before it's all talk. And
yes,
now
exactly.
This is the point where, okay, now you're in charge. So you see beautiful recovery of the gums here, and this is after your surgery, isn't it?
Yep.
How long did that take to heal?
My periodontist, he likes to push me out of cases until 3 months have passed, just to have proper osseous maturation, and he wants to avoid any gingival changes. He's very meticulous about this. So I just left her with the temporaries for 3 months, just to make proper gum healing and proper stable osseous levels.
Yeah, perfect. And you can see actually, guys, if I just point towards the final preps here and the difference between what we've got there, you've actually increased the height, which you're going to come onto, haven't you? But exactly. You can see very clearly here between the two pictures.
Exactly.
Right. And it's the next slide. I should have just waited.
So this case, after preparation and after taking off all the bad fillings and the old crowns, I saw that the abutments, they were very short. So having such short abutments would really hinder your resistance and retention form. And you have to know, Dr. Kazi, I also raised the vertical dimension of occlusion. So the force trajectories are increasing. So I just wanted to make sure that I have more than the minimum dimension of abutments that you have in literature. If you have less than 4 millimeters of abutment height, it's risky. I know the adhesion and adhesives and everything that we've been inventing lately. But of course, having more than 4 millimeters of tooth structure would definitely give you better prognosis for your full coverage restorations.
Yeah, so why not have both if you can do it? The height and the...
Exactly. And precisely in such cases, you want to have your safety margin as broad as you can. You don't want anything to fail, because the system that you're building right now with the muscles, the joints, and the teeth, and the periodontium, the whole stomatognathtic system, you're just covering everything, all the subjects. So
so you've done that.
I wouldn't care less about putting 2 millimeters of composite and taking it for 30 minutes. Definitely wouldn't bother me.
Yeah, no, and it's better to go belt and braces. It's like in ortho, you have your fixed and your removable retainer. Go for both. Why would you leave something, such a large bit of treatment, to chance?
Exactly.
Here we go. Prep guides.
I took this from a book that I like very much by Mauro Fradiani. It's called Static Rehabilitation Fixed Orthodontics, if you guys want to check it out. This is a silicon index, hard silicon index derived from the wax up that we did for the case, the approved wax up, as I stated on the picture. And I started checking out the dimensions that I have, because I want to feel safe that my ceramist wouldn't have any problems later on finishing up my restorations. And I don't want the articulator and the case going back and forth. So you're just not ignoring the signs that I've talked about in the beginning.
Let me see if I can zoom in. Yeah, again, so essentially what you're doing here is, I don't know if you guys can see that, is the bands. and you're checking that you have the right amount of space for the restorative material to fit
Yes, exactly.
between yourself, your the outside and the prep.
Yes.
Cool, love it. Next one. Here we have your preps again from the occlusal.
Of course, this is quite some time I didn't go for bridges. I like doing implants very much. I don't like to splint teeth together. But in her case, she was leaving very early and she had previous bridges before. And I just gave her oral hygiene instructions and we decided to go for bridges again.
Yeah.
So they are all full coverage restorations except for the upper left second molar. I went for an endo-crown preparation. I had a good amount of enamel to bond to, so I didn't go for full coverage there. I just went for a more conservative, if you can say, approach, which is the endo-crown.
Yeah, conserving this ring of enamel here. Otherwise, you'd be removing that and then left with not much left in the inside.
Yes.
So yeah,
exactly. The case from out there could look a bit invasive, but people have to know that I didn't prepare any intact teeth. They were all almost covered by previous restorations.
Yeah, so we're refreshing and adding height where we can. Okay.
Yes, exactly.
Where's my... There we go. It wasn't working for a second. Okay, there we go. So here we've got the lower arch again. Preps all round. Got a question from Victoria. Thank you for the question, Victoria. How much did you increase the height of the prep? We want more than 4 millimeters height. Is there a maximum height that you go for?
Let's take it from the other way, Victoria. How minimum thickness you want for your ceramics? The minimum thickness. I'm going for zirconia and Emax. The Emax could go for 0.7 millimeters. The zirconia you could go for 0.5 millimeters. So I just wanted to get more occlusal gingival dimension, and I also wanted to have proper crown root ratio. So I don't want to go all the way and I figure out at the end that my crown is longer than my the root. So I just increased the 4 millimeters. I just wanted to have a minimum of 6 millimeters for each abutment.
For each prep,
for the posteriors.
Okay, perfect. And then have you done much on the anteriors as well, or you've done a little on the top?
Pretty much a little, just to have proper emergence profile and to avoid any cohesive fracture that would happen later on for the ceramic restorations.
Yeah, I'm interested to know because I'm more on the end. I like endo actually. How were these teeth doing with their endodontic status?
Pretty much stable. She had all her teeth endodontically treated. My endodontist in the clinic, he found out some teeth that were, it had short root canals. So just we found out that if we can make the old root canal treatments, if they are stable enough and they have an apical seal, we would leave them. But for instance, her upper right canine and the upper right 6, the root canal treatment wasn't very proper. So we had to go for upper root canal treatments for the upper right canine and the upper right first molar.
Perfect. Yeah. Perfect. Yeah. So that I was just wondering because we have a lot of crowns. So I was wondering whether they were still, someone had done and left, nerves underneath there, or they'd gone for the whole full root canal.
Exactly. Yes.
There we go. So we've got the temporaries on for 4 weeks.
This is my test drive. If anything is wrong with those, I would just put it on a piece of paper and I would put it in the box of the patient. I have all the casts of each patient in a separate box. I just pin those papers down and take all the notes that she doesn't like about the aesthetics, about the movements, about the comfort, and anything that I don't like. For instance, in the temporaries, I wanted to raise the curve of SPI a little more. So I took this down and I adjusted it in the try-in, as you can see later on in the PMMA pictures.
Yeah. All in one appointment, the preps, or did you spread them out?
No, upper alone and the lower alone. 3 days separate.
Yeah.
Yes, and a third appointment just to occlusally equilibrate the temporaries.
Perfect. And then after 4 weeks, the patient has come back,
Yep.
feedback about these aesthetics, function, biology, and then you've got a Pankey jib for checking for the CR.
Yes, I just wanted to know that she has a pretty stable bite, and I made her do all the protrusive movements, and as you can see, the centric relation is right in the apex of the triangle. This was from the first go, so my patient is pretty much in a very deprogrammed state without any muscle problems.
Yep.
So the patient was pretty much deprogrammed in a centric relation comfort zone.
So that's the spot just here.
Yes, the blue one.
Yeah.
Yes.
Let me zoom so you guys can see that just in case. I always forget that I'm on my phone here, and some guys might not be able to see. So you can see here on the jig, you're looking to get it on this area here, and that's where we were. Okay, next slide, we've got Pankey jig again. Is that right?
Exactly.
From the lower.
Yes.
And here we've got the face bow.
Right now, Dr. Kazi, you want to transfer every piece of information that you have for your temporaries on the articulator again. So it's just like you're treating the patient all over again. So I wanted to take the face bow, the occlusal plane or the incisal plane orientation that I already have that the patient accepts.
Yep.
Then I'd go for mounting on the articulator just to copy everything that the patient approved and join this with the beauty of ceramics that we're going to see later on.
Yeah, so this is the double check stage. Make sure we didn't make any mistakes.
Yes.
We're going to use this wax up, functional try-in, whatever you want to call it, to go towards the final.
Yes.
Dentist with Smile says, amazing work, Dr. Mustafa.
Thank you.
Okay, so this is a sequential bite reg for cross mounting. How do you do this in practice?
So right now, I gave you 3 terms that I invented in my mind. It's just not there. So people, if they go look for it, they're not going to find it. But if you do things a lot, you're going to give them names just to make things easier for you. So we started with the exposition, Dr. Kazi, right?
Yep, so that was the front.
Yes.
And here, wasn't it? Yeah.
No. I'm just giving you the names that I invented in my mind. Yeah. The exposition for the incisal edge, for the incisal edges, the occlusion box that I told you about, and the sequential bite registration. If you didn't hear before about the cross mounting, it solves a lot of problem and makes your life a lot easier and your ceramist as well. Right now, the sequential bite registration, the previous case that I've done, it's just you want to maintain the video that you have with your temporaries. So this is the final bite registration picture that you have seen. But to take the 3 parts of the bite registration, I had to take the bite registration for the left area without the temporaries and with the right temporaries on the right side.
Yeah.
Then I wait for it until it sets. Then I do the right side with the hard bite registration on the left and with the new bite registration on the right. And when they set, I just place them and I do the front ones.
Yeah, to make sure that so basically you're section this side, for example, gun it in, wait for it to set, section that side, gun it in, wait for it to set, remove the center portion, and then do the third part.
Yep.
Easy now when you hear it. I'll do it tomorrow now. Here we have the natural dye selection.
Yes, this is a shade guide. The ceramists just have a gypsum model, hard stone model to fabricate your teeth. So I just want to give them an idea about my translucent ceramics. What would they be placed on, just to have better aesthetic restorations. So this is the natural dye shade selection. It's a totally other shade selection than the 3D Master and the classic Vita shade guide that we have for the final ceramics.
So this is to check your stumps, isn't it? So then you can
exactly the stump shade. Yes.
Perfect. And then we have the cross mounting there, and then we move to verification, which is you're checking from. Is this your wax up here?
No, this is the final impressions for the temporaries.
The temporary. So that, yeah. So then you're checking that this measurement here is the same as this measurement here from when we did your sequential byte registration.
Exactly.
Perfect. And it was good.
You want going through this case, you just want to make sure that you're going on solid ground. You don't have anything that you're missing.
Yeah. So you're double checking every time you do something to make sure that, you know, all these units are going to be okay once they're in.
Exactly. And you have to know that everything you're reaching right now, it started with a leaf gauge. So you can, right now you can imagine how things are escalating, right?
Yeah, it's building block upon block till you get to.
So you never ignore the signs to reach a good destination. I like the title very much. Okay.
Here we have digital design in accordance to the previous shape. So this is planning the restorations, how it's going to look at the front.
Exactly. My ceramist, my designer, Dr. Ahmed Khairi, we were just, I want to tell you that this WhatsApp conversation, the pictures you're seeing here, he just had to, we spent like 3 hours just sending back and forth. Just do the upper right line angle. Just accentuate the upper left canine. It's just going back and forth until we reached a proper digital design. Arjun, I think he just asked another question.
How does the ceramist recreate exact palatal inclines?
And this is a very good question. Arjun is beating himself today. I use a custom incisal guidance table.
Yeah.
This answers your question, Dr. Arjun.
If you're a dental student, please just take the BDS from the dean's office and go home. Just
Yes,
I don't
exactly.
think you can take the exams.
No.
PMMA try-in.
Yes, exactly.
There's PMMA try-in. Then we've got left and right shots. Lovely. So yeah, we can see really nice new occlusion and incisal level. Just jump in if you want to say something about these ones or anything left.
No, I just want you to take a good look at the curves, the curve of Spee and the curve of Wilson.
Yeah, this one here. Yeah, did we have a?
I occlusally equilibrated those again by using a leaf gauge.
Yeah.
As you know, those parts for I used the zirconia material, layered zirconia material for the bridges, just to have proper strength for the connectors. I never go for Emax bridges; it's too weak at the connector side.
Right.
So I just adjusted the occlusion. The lab he scans the occlusally adjusted restorations, and he puts this for the final milling. And for the PMMA, this is a castable PMMA. So he just casts the PMMA right into the Emax. So anything you're doing here occlusally for the Emax, it's going pretty well to be reproduced in your final restorations.
Yeah, and again, talking about the Emax versus
zirconia,
it's again really important that you had that extra height in the preps because you can't bond the zirconia.
Yeah, not etchable.
No. So it's really important. Again, another reason why that was a very key step.
Thank you.
Here we have the interior shot. Let's retract. And look at this, guys. I'm going to try and do an aesthetic pan. Okay, lovely. Do you bond and check the occlusion, or do you check the occlusion first?
Do you mean during delivery?
Yeah.
Do you bond and then check for occlusion, or check occlusion before bonding? If I'm going for a very delicate restoration, I would definitely bond, then adjust occlusion. But if I have proper thickness, it would be very easy for me to polish extraorally, then go for bonding later on with a purely polished surface. And I like polished surface more for the ceramics than doing overglaze.
Right. Perfect. And Dr. Shirley Zia is asking, what type of cement are you using to fix the translucency that we can see in centrals and laterals?
This is a very good question, Dr. Shirley. Uh, you can go for pre-shade cements, mock-up cement, but for this case, actually the PMMA showed me that I have very thin Emax thickness that you can see the stump shade through. So
Yeah.
I just told the lab to put a little bit of an opaque shade on this, and I used the milky white cement shade at the end just to cover up the stump shade.
Yeah.
As you can see, the discoloration
Yeah.
is the discoloration is huge.
Yeah, absolutely. And we had a question. Do you personally recommend the pre-shade cements?
Yes, I do.
Wonderful case. You just changed the patient's life. Kudos to you, Doc, for sharing. So you're adjusting the line angles here.
Yes.
Okay, to the next one. Any tips when adjusting line angles? Anything that you've picked up?
I picked up a lot the line angles. I just want to tell anyone who wants to get into prosthodontics, the position of the line angles and the direction and the curve pretty much shapes your ceramics. You could have brilliant incisal edges, the best translucency, the best porcelain building, but if you don't pay good attention to your line angles, things wouldn't come as aesthetic as you have imagined. So I just want to tell people, practice on your line angles a lot, a lot. They really change the final aesthetic outcome in a lot of cases.
Yeah, it's all about the reflection of the light and how it reflects around the environment.
Exactly.
Well,
Exactly.
there we go here, and then you've got your pin in there as well. What's happening here?
My ceramics just placed a reflective layer that shows the texture of the case, the buccal lobes. He just wants everything to be in harmony. So as you can see on the canine, you can see the buccal lobe of the canine, on the premolar also. You can accentuate the line angles more. You can see if you want to deepen or make any grooves that you have placed shallower or deeper. So it's a very important step. As you can see for the upper left central, on this case, the cervical area was very deep. You can see the color reflection from there. Can you see it, Dr. Kazi? Yes, exactly. It wasn't that evident on the white color of the unglazed porcelain. But right now you're getting a more reflective look just to adjust it before delivery.
So yeah, a final check to make sure you're not over contoured or under contoured in areas.
For the texture. You can do this during also if you're doing composite layers. You can do it with an articulating paper. If you're finishing up a direct veneer or so, you can get your articulating paper and just you rub it on your composite, and you can see this intraorally in the patient's mouth.
Yeah.
To check out the texture.
Arjun is again asking, any comments on digital articulation? Will it decrease our work of cross mounting?
I've never done cross mounting on a digital articulator. I'm pretty much, like I told you before, I'm pretty much an analog guy. So I think things will really improve on the articulation segment. Things are really getting better. But for me, I just like everything to be more tangible. I like to check out everything, all the movements on the articulator. I've never used cross-mounting digitally before.
Yeah, so we'll have to check that out when suitable applications become available.
Exactly.
Dr. Shirley, this will be replayed on YouTube. So if you missed the area when we were talking about facial position and the shape, we spoke a little bit about that earlier in the session. But yeah, you did have a little look at that as well, didn't you?
Yes.
So the replay for anyone who's joining is going to be on YouTube. If you're watching back on YouTube, thank you for making it this far through, and please make sure you hit the like button, subscribe, all that stuff. Here we have the inclines that we talked about for chewing efficacy. You can
Yes.
see there. So if you guys remember, it was very flat beforehand, wasn't it? Okay. And Victoria is asking what translucency of zirconia was used.
I just porcelain buildup. We just layered. We just did a cutback on the zirconia restorations, and we went for a buildup, porcelain buildup.
I hope that answers your question, Victoria. And then we've got the lowers as well, and final restorations in the articulator.
Yes.
Yeah, and you can see the reflection of the light.
Exactly.
Which here, which let's just go in. Which is very, very aesthetic there, obviously, as you can see. And here we have on the lower as well. Okay. Cool. Let's go to the next slide. And this is delivery.
Yep. Pretty long day. It took us 4 hours just to deliver all the restorations. But she was a very cooperative patient. She really helped a lot. This is why you should really think about patient selection before going into such cases. You have to have a very understanding patient to go out with such cases.
Yeah, and yeah, of course, it's all about picking your cases and making sure that the patient is on board, which is what you were very clear about early. You know, the patient really needed to be motivated.
Yes.
And so here we have what order do you go for when you're placing these? Is there a certain procedure? Do you do posterior first? Is there any way that you do it?
Would be very difficult. This would be a very difficult case if it was veneers. If I was doing veneers, I'd go for the midline, then to the back, just to avoid any problems with the symmetry and the midline. But for crowns, it was very much seated. I went from the right side all the way to the left side, and the lab, he did a great job adjusting those restorations.
Yeah, Dr. Shirley is asking, she thinks that the 9, 10, and 11 may be a little bit long. We'll see in the final pictures how the patient is. And then we have this curve B, which has been reproduced here and restored even. Okay.
By the way, those the line angles, the occlusal gingival height, the incisor gingival height for those center incisors, just to answer Dr. Shirley's question, 11 millimeters.
Yeah.
The centers were 11 millimeters.
Centers were 11 millimeters. Let me see. She's asking. You can see she thinks it looks a little long in the patient. But the whole point was to increase the length gingivally, wasn't it? Because we had some very short, stumpy looking teeth and a lack of...
and the gummy problem too.
There wasn't any of the lowers weren't showing in the initial, were they at all? We had 0 millimeters.
Yes.
So yeah, we can see here that the posteriors have been built up, and that's given us the space in the front. And we've managed to reproduce that anterior guidance as well a little bit, haven't we?
Yes, we did. You can see it on the next picture.
Yeah. So that's what we've come from. This is the final delivery, isn't it, here?
Yes.
And
those with the occlusal points.
Really important, this here.
Yes, exactly.
Okay, I hope you guys can see that. So what do you look for in your occlusal marking?
I'm looking that I have pretty much stable occlusal points. I don't have them on any inclined planes. As Dr. Michael Melkers, he's a great clinician, he said, if you have only 1 point on a full mouth rehab case, then you're having good success and less biomechanical failures later on. And as you can see for the canines, I went for a canine guidance occlusion. Some people are pro, some people are against, but I'm pretty much very comfortable with the canine guided occlusion. as all the literature that I've read, it states that the electromyographic measurements for canine guidance is pretty much less than for the group function. So I have better muscle relaxation during canine guided occlusion.
Yeah, absolutely. I think there's obviously a debate that lots of people like to have around there, but it's clearly worked here, and we can see that this is much more natural towards what the patient is. Much more natural compared to what we had at the start, and we can see here in the center as well. Here we go. Perfect. Interesting question. How would you sequence this if the patient can't afford all the permanent
temporaries
in one go?
Temporaries. I'd leave her with her temporaries, but I have to give her a time frame so that I can adjust everything that we've been doing. We can go for temporaries, of course, but would be very difficult if she prolongs the waiting period. I don't want everything to collapse back in.
Yeah, because that becomes a real issue, because all the hard work you've done with your leaf gauge and wax ups, you almost have to start again from zero if things are left too long.
Exactly.
Anika, thank you for the question. Did the patient have any concerns with temporaries, or later that you had to take care of it or make any changes to the plan because of it?
Yes, she did. She just talked about, well, she was a very nice patient. She came in with her iPad. She showed me a lot of pictures of people's teeth, and she told me, if you can play with the incisal embrasure. I just did. As you can see, and people told me about this case, the teeth, they have character. They are sharp. I started first by going for rounded line angles and point angles, but she didn't like it. She told me, I want sharp incisal embrasures. She wanted to increase the length of the lateral incisors. I went for an 0.5 or a 1 millimeter shorter lateral incisors, but she told me no, she wanted to bring them down. And I'm pretty much very comfortable with obeying the patient's aesthetic demand, because as long as it's not affecting my biological outcome or my mechanical outcome, it's their choice, just like the shade.
Yeah, totally. Yeah, as long as function is good, as long as we're not going to cause some failure as a result, then I think it's good to accommodate that. And it's maybe the whole point of aesthetics is to be aesthetic in that patient's eyes. Here we go.
This is a very nice piece that I got from a book called Global Diagnosis. It's a form of good aesthetics when you have your mid face and your lower face measurement has a 1-to-1 ratio. So thank God this is what we had at the end. Yeah,
and we had much, we had a bit of collapse, didn't we, because of the loss of
so exactly, very collapsed.
Big change.
Yes.
Big change there. Let's have a look inside here. So this is your
Amico.
Yeah.
Yes, this is called organic occlusion. I know some people, it's debatable also, but to have protrusive movement, you want to have them on the front teeth, and you want to have this occlusion on the posterior teeth. And for the canine guidance, you want to have you want to avoid any interferences on the non-working side.
Yeah.
So this is called organic occlusion.
Yeah, I think it's I thought that's pretty well accepted, really. To be honest. Yeah, I definitely don't want grating here when I'm bringing my mouth forward, lower incisors forward, and again the same thing. You don't want grating on this side when we're doing this excursive movement.
But I want you to imagine doing the upper picture with her old restorations. In order to reach her protrusive movement, she'd have to go on all her posterior cusps just to bring the first point of protrusive contact between her lower incisors and her upper incisors.
Yeah, due to that curve of Spee, which was so
yes, exactly, and the huge overjet that she had.
And there we can see that exactly what you're talking about here. Let me just pull inwards a little. There, you can see it. Very, very exaggerated from the lowest point here to the high point here. And then, yeah. There we go, 5mm overjet.
Which is acceptable. The optimum is 2 to 3 millimeters, but this is a class 1 patient. If I wanted to decrease the 5mm overjet, I would have proclined the anterior teeth a little more, but would be very difficult. It would look very bad later on.
Yeah, absolutely. And we can see here anterior guidance. So you can see the contacts, which is nice here. Perfect. And you can see you've added adequate thickness to do that.
Exactly.
And here's the post-op. Moving into history, pre-op, and then the post-op. And you can see that it is much more aesthetic. I think everyone can agree there. That's exactly what you would expect from a case like this. Okay. There we go. And somebody's asking about speech issues, and we have a handy video, don't we? Which is at the end. Is it the next video? It's the next. Oh no, the video is not on this one.
No, it's this. It's at the end of the video, Dr. Kaz.
Okay. Let me skip forward.
It's coming.
S F Z.
There we go. Yeah. Any questions, guys, in the
And
comments?
to answer Dr. Arjun's question, I did this phonetic video for the temps and for the try-in, and of course for the finals, as you have seen on this video.
Yeah. So that's really good there. Any further questions, guys? As a dental student, this is very complex, but very interesting and inspiring, nicely presented as well.
I'm very happy that you've liked it.
Yeah, there are much more simple cases that we've done, guys, on the YouTube channel. I think we've got 46 videos on there now or something, at least. Let me check, actually. Let's turn this around because we're finished on there. Oh, that was very close. Yeah, a great case. I was very happy to have you on. Let me turn this light back on.
Thank you. Me too.
And yeah, I think hopefully everybody's taken something out of that, and we can maybe learn some things. Even if guys aren't going to put this into practice, there's more understanding there of how these cases are done, which I don't think is covered brilliantly well in dental schools, certainly. So really great. What correction should be made if we feel that the speech is not clear?
Depends on which problem did you have. If most of the time it's related to the upper centrals. If I'm having the patient having a very whistling S, I'd go for I'd create more space. If the patient doesn't have a proper S, she has a lot of space, I'd block the closest speaking space a little. For the F position and the V position, it's more related to the position of the incisal edges towards your vermilion border, the wet and dry line on your lip. So this is how you adjust phonetics, and you go back in and you try to make the patient relate more and train more during reading out loudly to adjust her musculature more to the new phonetic position.
Yeah, hope that answers the question. Guys, this is where the replay will be. So if you head over to the YouTube channel, there are currently 34 videos on there. We have 48 podcasts as well for you to look at, and Instagram for dentists as well. So if you want to find that on YouTube, you can do that. Link is in my bio there, or you can just search Hotball Podcast, which is where you can find all these things. Let's just turn that back around and have you back. Name the article that you said about the 1, 2, 3 articulator rule.
It's an article by Dr. Marcelo Calamita. Just go on, write vertical dimension of occlusion, Marcelo Calamita, and it will pop right up. It's a very good, nice article. you'll like it. You'll like it a lot.
Perfect. And if you can't find that, I'm sure the doc will be able to send you a link in the
No problem.
in the DMs or something afterwards.
Of course.
Yeah, I mean that was an amazing case. Especially, I think it was really good for us to have a real look at reorganizing the occlusion and step by step how it's done, because
Exactly.
it's not something you see explained properly lots and lots. I know there are more ways of doing it than just this way, but at least we've kind of stepped into that world now, which is a little bit mysterious and confusing for a lot of guys.
See, I teach in a university here in Egypt, and I have a lot of undergrad students. Of course, explaining everything like this to an undergrad would be a lot to acquire and a lot to understand.
Okay.
So if you're really, really interested in such cases, you'd have to have a very, very profound foundation. You'd have to be superior in your implant information, your prosthetic information, your endodontic information, in order to be pretty much sure that your case is going to succeed later on. So this is why all the information that I've acquired for full mouth rehabilitation, it really came out after finishing school.
Yeah, yeah. I think that's where a platform like mine hopefully will come in for you guys.
Exactly, exactly.
Which
it was an honor to come with you, Dr. Kaz.
Thank you, thank you. I mean, I'm very early out of university. Only 2017 I graduated, and I've had a gap year or so from coronavirus, so I've taken time off. But hopefully, you know, these videos that we're doing,
it really links up between the upcoming generations and the one who really thought to just spread the knowledge more. I just want people, if there's a take-home message for any dentist out there, just know that there's nothing impossible to learn if you start by working on yourself, reading a lot, doing a lot of cases, finding mentors to follow. I want to do a shout out to Dr. Lucas Lassman, if you know him. He's a great doctor and especially focused on this subject. Would be really nice if you can look out at his articles and literature.
Yeah, awesome. So we'll hopefully have a look at those as well. I wonder if we can get him on some point and see if I think it's difficult to get these big guys sometimes.
No. He's a really humble person. You should go check him out.
I'll try and do that. Guys, I think we're going to leave it there. It's been an hour and a half. If you've enjoyed this, make sure to head over and follow Dr. Mustafa on Facebook and on Instagram. You're new to it. My phone's telling me we're running out of battery. To follow Dr. Mustafa on Facebook and Instagram. You're posting a lot of your cases on Facebook, on Style Italiano, on Bright Global, and a couple of other groups as well. So if you want to see more cases like that, that's the place to go. I think I'll definitely be poaching more clinicians from Facebook from now on, because this was a very, very good presentation. What else do I need to tell you guys? Make sure to go to the YouTube, guys, and follow there. I'm trying to get verified on YouTube, so you guys have got to watch a couple of hours of video each, please. And we also have some merch. But very quickly, we have a couple of bits of merch. We've got, you know, mugs, one for the girls, one for the guys, and some other stuff. So if you're enjoying the stuff, make sure to head over to the link in my bio and check that out as well. Dr. Mustafa has been great. Amazing.
Thank you. Thank you. You too. See you later.
Awesome, guys. I will see you guys in the next one. Yeah, definitely. I'll see you guys all in the next one. And hopefully you have a good day.
You too. Bye-bye. Bye-bye, bro.
Bye, guys.